well, let's get going. Got a few good cases for you guys, some kind of quirky one as well. All right. Anybody want to give this one a go?
I'll do this one, Dr. Cockerell. This is Yasmin Coffee.
Okay.
So looking at this at first, going between inflammatory versus neoplastic. I think this is neoplastic.
Good.
And then the first thing that catches my eye is how symmetric it is and also well circumscribed. I'd say it's a benign lesion because of the pattern.
Excellent. Very good.
And then what catches my eye are these nests of cells right in the epidermis.
Okay. So what kind of differentiation do you think we're dealing with here?
I'm sorry, it cut out. You said what type of
Differentiation.
differentiation? I would say
Like epithelial and non-epithelial.
Oh, epithelial.
Okay, it could be, and it's a type of epithelium. And if you wanted to get a little bit more specific than that, what would you say?
I would say, I think it's melanocytic.
Yeah, good. Melanocytic. Excellent. So we've got a small, well-circumscribed melanocytic lesion, benign. So what's the overall diagnosis?
Overall, for like a reed nevus, is that was what I was going for versus like a Spitz
or nevus, right? So nevus, and then say, okay, it is a nevus, and then there are a lot of subtypes of nevi, right? And you said reed nevus. Tell us about what a quote reed nevus is, quote unquote.
So with the reed nevus, you'd see, I believe it's like a Spitz nevus, but here it's pigmented.
Yeah, it's a variant of a Spitz's nevus, and the lesion, they're usually very heavily pigmented. As you can see here, it's very dark and black, probably clinically. The cells are usually comprised of these somewhat spindle-shaped cells, but they can sometimes be somewhat epithelioid, like some of these cells down in here. Of course, that's the other name for Spitz's nevus. Nevus is spindle and or epithelioid cells. Sometimes they can have cheminobodies. It's possible that might be a cheminobody. It may just be a little keratinocyte there that's pink. These more likely to be cheminobodies over here, dull pink globules that we see in Spitz's nevi very commonly. Okay, so that's one type of nevus. What are some other types of nevi that you know about?
We have, like melanocytic nevus.
Well, there are other types of, they're all melanocytic nevi, basically talking about the melanocytic lesions. Yeah, we're not talking about epidermal nevi and those kind of things, but what other kinds of melanocytic lesions? So let's say that you're on a board examination and they have pigmented spindle cell tumor of reed as a choice, but they might have some other things on there that you might have to make sure that they don't confuse you.
Okay.
Heavily pigmented. So what do you think about when you know,
melanoma?
Super heavily pigmented?
I'm sorry, it's cutting out for me, but I was going to say you'd have to make sure it's not a melanoma, but
yeah, that you certainly would want to put melanoma as a choice. What about a blue nevus?
Okay.
It's heavily pigmented, so you might say, well, you know, it's dark and blue nevi are heavily pigmented as well, but that wouldn't be the best choice because it's got those other features that we mentioned before. There are other kinds of nevi that that you can read about in the literature that, you know, just make sure when they put some of these nomenclature on an exam that it doesn't kind of throw you for a loop. So if they put something like pigmented epithelioid melanocytoma, for example, that's kind of a lesion that's very heavily pigmented. It looks more like a variant of a blue nevus in many ways, but it's got some epithelioid cells in there. We used to call those lesions years ago spitzoid blue nevi. So that's another theoretical choice that they might throw in there. They might even put something non-melanocytic. They might put something in there like maybe some kind of hemocytotic dermatofibroma or something like that. So when you just see something that's really dark like that, you want to think about that. Now, what are some other types of Spitz's nevi? So this is one subset of Spitz's nevus. This pigmented spindle cell tumor of Reed is the other name for it. What are some other types of Spitz's nevi? And now, since it's been a relatively hot topic in the literature in the last few years, they might actually ask you a question or two about this.
Okay. I'm trying to remember different types.
What's the most common type of Spitz's nevus? What's the setting where we see it most commonly?
In children?
Yeah, in children.
Yeah.
And if you biopsy what do they look like clinically most of the time?
Papules.
Kind of an orange or skin-colored dome-shaped papule, most commonly. Now, they can be pigmented, but they're usually small dome-shaped lesions with sort of an orangey, reddish color to them. They often get sent into us as rule-head hemangioma or something like that. Clinicians aren't thinking of Spitz's nevus in many cases. And if you biopsy that type of Spitz's nevus, does it look like this?
No.
No. What does it usually look like?
I know that it doesn't necessarily look like this with the pigmentation that this has.
Right. Those usually don't have a lot of pigmentation. They may have a little bit. And the cells are often round, more epithelioid. They can be spindle also. And then there's another variant where the cells can be really spindle and almost desmoplastic. And a lot of those Spitz's nevi have been reported with genetic abnormalities now. That's why it may be important to kind of know about that. 11p gain or loss of chromosomes have been associated with some of those lesions. They have RAS mutations associated with them as opposed to melanoma, which don't have those same types of mutations in them. And they sometimes will have more of a verrucous epithelial hyperplasia overlying them. So, and then there are certain Spitz's nevi that have ALK fusion mutations. So just realize that there's now a literature on looking at the genetics of Spitz's nevi as well. Just like we've been looking at genetics of melanoma and genetics of some of these pigmented spindle cell lesions. There's now people that are looking at the genetics of these Spitz's lesions. And so they might show you an example of one of those. It's kind of got that desmoplastic morphology and ask you which type of mutation might be most commonly associated with that. Now, this is a pretty classic example of this lesion. What would you tell the clinician in this case? So let's say this is a 5-year-old kid and it's on here and they took a shave biopsy. What's your clinical recommendation there?
That it's benign and we don't need to excise this.
Good. Excellent. So you don't need to excise every Spitz's nevus. It's a little different story if you've got an equivocal lesion. Maybe say it's got a few features that are suggestive of melanoma, but it's not an equivocally melanoma, and it's maybe on the thigh of a middle-aged woman, which is kind of the other subset where we really see Spitz's nevi most commonly. The most common is in children. The second most common are younger middle-aged women. Those, if we're not sure, we may submit them for additional genetic testing, or we might recommend conservative removal because it's not a child. But not every Spitz's nevus needs to be excised. And if it's an obvious classic Spitz's nevus, even in an adult, even in an older adult, it doesn't have to be removed. So I think it's just an important point. It's not a precursor of melanoma. The main problem is that sometimes it's difficult to distinguish the histology between a Spitz's nevus and a melanoma, because they can be, you can get pagetoid spread of melanocytes, you can get mitotic figures very commonly in Spitz's nevi, but it doesn't mean that it's cancer. So that's good. Okay, good. So that's good case. That was a good example of a pigmented spindle cell tumor of Reed, which is a type of Spitz's nevus.
Thank you.
This one. You're welcome. It's good job. Okay, who wants to do this one?
Hi, Dr. Cockerell. My name's Yelena. I'll be doing this one.
Okay.
Okay, so starting off, we can see from afar, there's this ovoid kind of shaped structure, and it kind of looks like skin from afar, but closer, it kind of has that more refractile property that's associated with chitin which can be found in some arthropods,
Good.
even kind of yellow and gold in some regions, and certain cuts towards the top, also kind of hinting towards chitin. And then looking kind of at the middle of the structure, it could be possible arthropod organs such as like eggs or just other internal kind of gut structures.
Okay, good.
And there's even a little bit of skeletal muscle there that's appearing
Yes,
in the
there is,
middle.
absolutely. So we share we share a lot of properties with primitive organisms, don't we? I mean, that looks very
Yeah.
much like the same type of skeletal muscle that you'd see in your own body if you took a biopsy of your arm, for example.
Yes.
And
And
this is
that's
interesting. Also, muscle here. It's got striations there, so you can see that this is skeletal muscle.
yes.
Any idea what this structure is?
That could be a mouth, perhaps.
Yeah, it is. It's kind of a mouth part structure. I think you said this was the golden
Yes.
colored area. Good.
Mm-hmm.
Any idea what this structure is, what this thing is?
So I was kind of between two things for this, like tick versus tungiasis, the sand flea. But for tungiasis, I think it kind of like more so burrows into the foot. So we would see acral skin kind of surrounding this worm-like thing. And it would just be kind of like buried into the acral stratum corneum. Whereas with the tick, I think it's more typically attached to the skin. So then it could just kind of fall off and then we could biopsy it in this way.
Yeah, no, that's exactly right. And if you look at the across, usually what we'll do when we get a biopsy of a sand flea or tungiasis, you're right. It's usually a biopsy of skin and it's embedded in there because it does burrow into the skin. And you will often see it in cross section, and you may even see the little the arms, if you will, because they actually have. It's a flea and it's got arms. This thing is an early. It's a tick. It's probably got some little legs in here somewhere. They're not easily seen here, but the mouth part is diagnostic. I mean, if you see this structure right here, this is pathognomonic of a tick right here. So I'm glad you recognize that. And so often we'll get these sent to us, surprisingly, as like rule out melanoma or things of this nature, because it's a black, often when they've taken their blood meal and that blood kind of coagulates and it gets kind of dark inside the tick, and the tick itself can be kind of dark. Sometimes clinicians think they're dealing with a melanocytic neoplasm. It's obviously not that. But this is pathognomonic of the mouth part. And when the tick actually attaches to your skin, there's a little chemical reaction that goes on here. It sort of dissolves your dermis and then it secretes, some people think it secretes some material that's kind of like a cement. And so it really attaches quite strongly to your skin. It kind of goes into the level of about the upper reticular dermis. And so if you just reach up and just grab the thing and yank on it, this will remain inside the person. So it stays inside that in their skin, and then you get a significant foreign body reaction around that, and it can be pseudolymphomatous and look very inflamed. But you'll see the tick mouth part, and you usually see some little pink degenerated collagen and that cement-like structure that surrounds the mouth part if they just sort of pull it out. So you have to have some sort of a technique. Some people use like a match that's kind of warm and they blow it out and touch it and the tick kind of releases. There's some other techniques that you can use to get it out of there without leaving that mouth part in. But that's probably the most important thing, that you can end up getting a pretty significant brisk pseudolymphomatous reaction to that. Now, I don't know that they're going to show you on the exam something like this. They might show you a clinical photograph, and then they might ask you which diseases are associated with this arthropod, and they might list a number of things. So what are some tick-borne diseases that we have to be concerned about?
One is Lyme disease. That's like with the Ixodes tick, and the organism is the Borrelia burgdorferi.
Yeah, good. This is probably a little too big for an Ixodes tick. I'm not sure about that, but it's sort of looks like this is more like just and this came from this part of the country, so it's probably more like a derma tick, you know, one of those kind of ticks. So those ticks carry different diseases, as you know.
Like Rocky Mountain spotted fever.
Yeah, Rocky Mountain spotted. That's probably the most serious one. What's a new disease that's now recently come on to the scene that ticks carry?
Are you thinking like the alpha gal thing?
Yeah, good, excellent. Yeah, that's the newest thing, that you get this sort of allergy to proteins. And people get bitten by a tick. It causes this cross reaction that then leads to people getting allergic reactions when they eat beef and things like that. It's kind of an interesting thing. And then there's I think it's the tick paralysis, where this thing is somebody gets it on their scalp, and you know, they have a tick bite in there, and then they start getting muscle flaccidity. And that's also possibly related to the same thing. There's one other entity, though, that you should at least know about that is carried by probably an Ixodes-like tick. It may be carried by these ticks as well, similar to Lyme disease, but it's not Lyme disease. We haven't actually been able to isolate the Borrelia from it yet, but it's got all the symptoms of Lyme disease. It gets an erythema chronica migrans like eruption. They can get some of the same symptoms as Lyme disease, but it's not actually Lyme itself. Anyone know what that disease is, what it's called?
Southern tick-borne illness.
Good. So-called Starry syndrome. That's exactly right. So in other words, we think of it as sort of Lyme disease. It's not from the Northeast. It's down more in this part of the country. So if you see someone that's got what looks like ECM, you biopsy it and it shows a lymphoplasmacytic superficial leaf infiltrate. They got symptoms that may be analogous to Lyme disease, but they haven't been to the Northeast. You want to think about that disease. So that's good. They could possibly ask something like that on the exam. Okay, very good.
Thank you.
You're welcome.
Hi there, I can take this one. This is Eugenio or Kenny. So it looks like we have a punch, kind of low power view. It looks, I would say probably this is on the neoplastic side instead of inflammatory. And
that's good.
I thought it was probably benign. You can see it's kind of circumscribed. You can see where it cuts off. And,
good.
You know, either kind of epithelial or kind of follicular differentiation.
Okay, good. Excellent. So that's basically follicular is one type of epithelium. Okay, so I think you're totally correct. Everything you've said so far is right on target. That's exactly right. Let's go to higher magnification, take a look.
So you see, of course, like the most obvious thing is kind of these basaloid kind of islands. Some of them are a little bit cribiform. And then this like cellular kind of stroma with like fibroblasts surrounding some of them.
Excellent. Yeah. And notice that if you sort of took all of these follicles and sort of crunched them together and then, you know, concentrated them in a little sort of vial, and then you took the stroma and did the same thing, which do you think would predominate?
You mean like between the basaloid,
Between the epithelial component and the stromal component, which sort of is actually a little bit more prominent here? There's a lot of epithelium, but there's also a lot of stroma too.
Yeah, I would say maybe the stroma leans a little more.
Yeah, and that's a helpful clue when you're looking at some of these adnexal neoplasms that are benign versus like a cancer, like a basal cell carcinoma, for example, or Merkel cell or something like that. They have stroma, but the stroma is not part and parcel of the tumor. The tumor is the neoplasm that grows and there's a stromal reaction to it. But when you've got a hamartoma, it's actually a combination of the stroma and the epithelium. So that's a helpful finding if you notice that the stroma is present very prominently with a lot of fibroblast and perhaps even more prominent than the epithelial component. It's just a clue. And what's another clue that this is more likely a benign rather than a malignant lesion here?
So at least some of the features I was noting, like there's like peripheral palisading, but not much stromal retraction.
Good. That's another one. And the reason for that is that the stroma is part of the lesion. In other words, this is recapitulating what part of the follicle would you say?
So I know there's like the papillary mesenchymal body. Sometimes you can see here.
Yeah, which is basically the inferior portion of the follicle, where that's the primitive germinative part, or could be the mantle zone area where you've got those stem cells. But probably we would sort of think of this as being more of a neoplasm involving the lower part of the hair follicle. So you can get neoplasms that involve the upper part, like say an infundibular cyst, for example, or trichoadenoma, which look like little multiple small kind of milia. And then you can get sort of the mid portion, the isthmus, where you get like so-called isthmus catagen cyst. And then you get the lower part, which is more the primitive germinative epithelium. So basically, it's recapitulating that. And if you think about the hair follicle, when you look at the base of the follicular hair bulb, it's got the papilla, which has got that fibroblastic reaction around that. So this is really making a little tiny primitive inferior portion of the follicle with the stroma and the epithelium. You know, it's a neoplasm. It's obvious it's benign, so it's a hamartoma. So do you have any idea what the name of this would be?
So I was leaning towards like kind of a trichoepithelioma or trichoblastoma, depending on like if it's a little bit deeper in the dermis.
Good, excellent. So this is more like what we call a trichoblastoma. And obviously, when you think of blast, you think of kind of more primitive. So this is really differentiating toward the very primitive stem cells of that inferior portion of the follicle. And just like that, this is a little nice example of a little papillary mesenchymal body. There you see the little small papilla that's there. And so it's trying to form these little hairs. And usually you don't see any actual hair shafts. I mean, you might see a little tiny some keratinization, but these things usually don't undergo cornification, so to speak. They just look like these just primitive little inferior follicular structures. And a trichoep, generally, like you said, not this deep. Trichoep doesn't usually only differentiate toward the inferior portion of the follicle. You'll also get some little cysts or milia there. You may get some calcification. So if you saw something just like maybe this part of it, and this was all you had, you might think it's a little bit more like a trichoep, but I like the trichoblastoma diagnosis better. There's several different subtypes of that. I don't think you really need to know that for the board examination, but there's one type that's kind of a rippled pattern. When you see it, it's more of kind of a more diffuse, more epithelial than stroma in that situation. That's kind of almost kind of like wavy structures of the individual neoplastic cells. There's a couple of others that some can look more like a classic trichoepithelioma. It's just bigger and deeper. And then there's this form, which is the most classic form. Now there's an interesting variant of this. There's a so-called trichoblastic basal cell carcinoma that can look pretty much, if you just look at the individual cells, they kind of look a lot like this, but you get very, very large aggregations of those, not just these small aggregations that are many. And they're situated in the dermis mostly without any epidermal contiguity. And clinically, they're thought to be a cyst, and they can often occur in sun-protected areas, the scalp, the groin, in African-American patients that have skin that's not damaged, they're not caused by the sun. And so that's a variant of a basal cell that looks like a trichoblastoma in a way, but it's far more cellular and far more epithelium than stroma in that situation. So that's good. Any questions about this one?
So just on the trichoblastic BCC, on that one, I was looking at, so BCL2 can sometimes be used to like compare like BCCs and trichoeps or trichoblasts. And I know BCL2 kind of like stains BCCs more. Do you still see that with like the?
Yeah, I don't use BCL2 terribly much in our laboratory. Generally, I just rely more on morphology. You know, if you see a trichoblastic basal cell, it's going to be a deep, large lesion that's asymmetrical, and you know you're going to want to excise that anyway. And so, even if it came back with a negative BCL2 stain that didn't sort of favor a classic basal because it was more primitive, it wouldn't really change my mind. I still want to make sure it's removed, but it's mainly just one that it's a variant that you just need to realize it sometimes can simulate non-basal cell cancer is thought to be a cyst or something clinically, and it's in an area that's not classic for basal cell, like the face, nose, that sort of thing.
Okay. All right. Thank you.
Okay, take a look at this one.
Okay, I can take this one. So this was a shave biopsy. I have mostly a differential diagnosis for this, but I was thinking maybe neoplastic. The epidermis, so there's some areas of compact orthokeratosis. There's a lot of extravasate or some sections of the shave. You can see those extravasated RBCs and then quite a lot of solar elastosis.
Yeah, a lot of solar elastosis. Exactly. That's very, very prominent here. Was there anything else that you saw other than solar elastosis?
I think other than the RBCs and solar elastosis, I didn't see much more
This
in dermis. Oh.
kind of change here. This is kind of subtle, but the reason they took this biopsy was they were worried about skin cancer. So they said, uh-oh, this lesion's kind of erythematous, it's got some dilated vessels, it's on sun-damaged skin, and it's actually in a site where there had been some previous procedure performed. So they want to make sure this wasn't like a recurrent cancer.
Okay, so like some fibrosis or there.
Yeah, now I'll call your attention to this. This is a little more subtle than, we had a case just last week that we would have been a better one to put in here, but obviously this was something that we submitted a long time ago. Notice this collagen change here, this change. Is this fibrosis here?
Or sclerosis.
Sclerosis. Yeah, the collagen is homogenized, as you can see that. And notice that right in this area here, there are no fibroblasts whatsoever. So when you see that, that's sclerosis. Now that changes your differential diagnosis some, right? So if it's got an increase in the number of fibroblasts, what are some diseases where you get that, or conditions where you get that?
So you could get that in like connective tissue disorders. But I'm trying to think more in like the skin cancer category, what that would go with. And I'm having trouble thinking of examples.
Well, yeah, if you just, let's say you had like a scar, a keloid, those get an increased number of fibroblasts. Nephrogenic systemic fibrosis, it's a fibrotic condition, things of those nature. Fibromatoses, those have an increased number of fibroblasts. But what about conditions where there's sclerosis? Fewer number of those that we think of, right? What are some diseases that where there's actually sclerotic versus fibrotic collagen, or dermis, rather?
Like scleromyxedema or dermatofibromosarcoma protuberans.
Well, not really.
Increased fibroblasts, sorry.
Yeah, what's the classic condition where you get sclerosis of the dermis?
Like scleroderma.
Yeah, good. Scleroderma, morphia, sclerodermoid PCT, all those conditions you get sclerosis. Where else can you see sclerosis? What's the second most common that you see in the derm clinics where you get sclerosis?
Like lichen sclerosis.
Yeah, good. LSNA. Those are the two most common where you get sclerotic collagen that you're going to see on a routine basis. And there are a lot of other diseases too. Now, what's another one where you also notice these fibroblasts here outside the zone of the sclerotic collagen? They're large, they're hyperchromatic, they look kind of bizarre.
Like epithelioid cell changes, or
Well, they're bizarre, atypical fibroblasts associated with sclerotic collagen in an area where maybe they had a skin cancer treated by a certain type of treatment. Does that ring any bells?
Oh, like a radiation?
Yes, good. Chronic radiation dermatitis. Now, this is a hard slide here. So if you didn't just pounce on that diagnosis, don't worry about it.
Okay, sorry, I was going down a different path. So
Yeah,
I
it's kind of
appreciate
a,
your help.
yeah, that's okay. We're learning here. We're not expecting everybody to get everything right all the time. But yeah, this is what you see in chronic radiation dermatitis. This was a person that had a skin cancer. I think it may have been on the head and neck area, treated with SRT. And it sort of developed an eroded, crusted area with some erythema here, probably just because the skin is no longer perfectly normal after that. It's not, you do get some chronic radiation dermatitis, even with SRT therapy that you fractionate out significantly. And so here they probably said, uh-oh, maybe the cancer's come back. So they took a shave biopsy and it didn't show the cancer. It just showed this area of chronic radiation dermatitis with these dilated blood vessels and extravasated red cells here. And it simulated a cancer clinically. But this is what you see when you get chronic radiation dermatitis. And they'll show you a better example of this on the exam. So don't worry about this specific example. It's not as good as it could have been, but this is what you do see when you see that. You get sclerotic collagen. You'll often get dilated blood vessels like this, and then you'll get these bizarre fibroblasts associated with it. So those are the three cardinal features of chronic radiation dermatitis.
Thank you.
The sun damage is probably just from their background sun damage itself. You don't usually get a lot of solar elastosis like change with chronic radiation dermatitis. It usually gets more of this kind of change. Any questions about that one? Okay. Take a look at this one.
Hi, this is Taylor. I can do this one.
Okay, great.
So we have a shave, and my first thought is that it looks more inflammatory.
Good.
And I was initially wondering if we had an intraepidermal blister, but I actually think it's just how the slide was processed.
Yeah, this is probably a couple of different pieces of tissue. This one's kind of folded in a different way here. What part of the body do you think you're from here?
Yeah, so we're missing the stratum corneum in a lot of areas. I think we could be on a mucosal surface.
Good, excellent. No stratum corneum, that's a good clue. Often you'll see pallor of the upper part of the epidermis or the epithelium here. We don't see as much of that here, but we got a little bit of that here because it's glycogenated. But and you thought it was more of an inflammatory process. Let's take a look at this one.
Yeah, I was thinking we had kind of like an interface dermatitis and a lichenoid band of inflammatory cells.
Good, good. A lichenoid pattern of inflammation. Excellent. So lichenoid dermatitis, and then what kind of cells were in the infiltrate?
Yeah, so we have a lot of lymphocytes,
Good.
and I also saw some plasma cells in there.
Good.
And maybe a few neutrophils. I think I even saw some neutrophils scattered in the epidermis in areas.
Yeah, I agree. That may be probably just kind of some irritation or something like that phenomenon. I agree with that. But I agree, down here, it looks like it's mostly lymphocytes with some plasma cells. Okay. So what's your differential diagnosis?
Yeah, so I was kind of looking at the superficial perivascular dermatitis Ackermann algorithm. And if we look at the lichenoid with lymphocyte predominant, we kind of have a differential of lichen planus and its variations. There's also lichenoid drug, pleva, graft versus host, MF. But really, given these plasma cells, I was more thinking along the lines of like Zoon's balanitis, or even syphilis, or scabies. But I think my top differential for this one, given the location and the plasma cells, was the Zoon's balanitis.
Good, excellent. Yeah, and that's what you should do, is when you look through a differential diagnostic list that sort of has everything in there, quickly eliminate the ones where there are other features that just don't make any sense. Obviously, pityriasis lichenoides doesn't occur on the mucous membrane, so you'd probably wipe that out, right away. There aren't any eosinophils, so scabies, you'd throw that out, and usually scabies is not a lichenoid infiltrate; it's usually superficial and deep wedge-shaped infiltrate, and we don't know what the depth of it is, but certainly it'd be less likely for that. So probably the three that you would really want to consider the most would be syphilis, lichen planus, and you mentioned Zoon's balanitis. There's one other one I would throw in there though, especially given this location. I
Hmm.
don't think it's that, and there's a good reason for that, but there's one other entity that I at least want you to think of when you think of lichenoid inflammatory infiltrates on the mucous membranes, besides those three that are absolutely correct.
I'm not sure.
Good answer. That's just fine. Early lichen sclerosis, early lesions of lichen sclerosis atrophicus will give you a lichenoid infiltrate. Before you get a lot of sclerosis, it can look like this. Usually, if you're going to make that diagnosis, you'll see some papillary dermal edema, and you'll see maybe a little bit incipient sclerosis. So I agree that's not the answer here, but that's another thing to think about. So those, if you want to kind of get a quick, short differential, you get a lichen infiltrate on the mucous membrane. Those four things are the main things that you would think about right off the bat. So that's good. So of those, this actually happens to be Zoon's. So you're exactly right, Zoon's balanitis. Now tell me a little bit about what Zoon's balanitis is thought to be.
Yeah, so I think the etiology is unknown, but it's typically presents as like a red plaque on the mucous membrane. I think it's more common in uncircumscribed males. Maybe it's due to like irritation or something of that nature.
Yeah, it is. It's the man might be uncircumscribed, but it's usually uncircumcised men. But yeah, that's correct. It is seen more commonly in uncircumcised men. And we don't really know what it is. It's probably some sort of an irritant reaction, like you said. Some people think it's a variant of lichen planus, just with more plasma cells, because plasma cells tend to occur on the mucous membrane sites anyway. Anytime you get inflammation anywhere in a mucous membrane site, from your mouth all the way to the lower GI tract, there are plasma cells in there because it's making IgA. And so you'll always see plasma cells in there, but you certainly would think about syphilis here too. And I believe that this was worked up for syphilis it was negative. So that's good. But I'm kind of a lumper rather than a splitter. I know Dr. Rapini's a lumper also, and I tend to think of this as being probably some unusual variant of LP in this location. And you see it clinically, it's red, it's erosive. It looks kind of like erosive lichen planus. Okay, great. That's exactly what that was. So good job on that too. Well, this one is board 101.
Hi, good morning, Dr. Cockerell. My name is Annie. I'll take this one. So it looks like we have a deep punch right here. From a lower power, it looks like we have a lot of inflammation in the fat. A lot of what's going on is in the fat area. So I would start thinking about things like a paniculitis.
Good, excellent.
In terms of differentiating it between like septal and like lobular, like the septae look really widened.
Good.
So I'd lean more towards a mostly septal paniculitis.
Good.
I don't see like any like obvious signs of like vasculitis from this pattern. Going closer, I see like in the septal areas, like a lot of lymphocytes, some histiocytes, maybe some giant cells as well.
Good. So what's the diagnosis?
So when looking at like septal paniculitis, I would think about things like erythema nodosum is one of the classic ones. Could also think about something like lipodermatosclerosis as well.
How long would you think about that? A millisecond and then throw it out, I hope.
Yes.
Because that never gives granulomatous inflammation. Okay. So that's good. Now, isn't it interesting? So what is this phenomenon right here, though?
It looks like there is like a little bit of like that crinkled appearance. So I would think about like, it's like the hyaline fat necrosis.
Yeah, this is what we call membranous fat necrosis. And that's actually is associated with ischemia and is seen in patients that do have lipodermatosclerosis. So I'm glad you at least mentioned it, because the last thing I would want you to do is they show you this slide on the exam, and it's a classic, beautiful case of erythema nodosum. It's got 100% of the criteria. And you start looking at it and you see that, and then you look down and they say, what is the correct diagnosis in this patient? And they have erythema nodosum, nodular vasculitis, subcutaneous fat necrosis of the newborn, and sclerosing paniculitis, parenthesis, hypodermitis, sclerodermiformis. And you see this and you start worrying about it because you say, oh my God, you see that in sclerosing paniculitis. Maybe that's what it is. But never allow one small thing to dissuade you from when you've got every other criterion that's perfect for a diagnosis, you know? So let's say you saw a small area of some, a tiny focus where there might have some dystrophic calcification of elastic fibers that look like PXE. Don't let that just change your mind. Say, oh my goodness, this guy's really got PXE because he's got a little bit of calcified elastic fibers. So don't let a distracting histologic feature change your mind when every other criterion is there. So make sure you know how to apply the criteria, which you did very well. So yeah, I wouldn't even, you could think of it, but very briefly, because it's got everything else that shows nodosum. What they would probably do on the exam, they might ask you, they might try to fool some people that would choose that, but they would probably show this and then start asking some second order questions, like which diseases are associated with this? You know, and what are some diseases that are associated with erythema nodosum?
So it's like these painful nodules. You can see it in things like sarcoidosis,
Right.
like a fungal infections.
Good. And that's kind of, you know, standard stuff. You know, they ask, when you look at the board examination, about 75 to 80% of it is fair, straightforward. If you've done a residency program and a good little program, and you've had like textbook conferences and conferences like this and whatnot, you'll get them right. You know, they want to just make sure that you're competent as a dermatologist. And so you should know what this looks like. You should know what kind of biopsy to take. You should know the disease that are associated with it. So that's, you know, it's fair. And then they have a certain percentage that are sort of esoteric questions, you know, like maybe they ask you the genetics of Spitz's nevi or something like that. So those are less common questions. And so they probably wouldn't expect you to go down that pathway if they showed you something that's classic like this. So just understand the way that they test. And this would be something that they probably would expect most everybody to get pretty quickly. And they might ask some second order questions off of it. Now, there are two different sort of types of erythema nodosum. This is just sort of a extra added bonus question, if you will. What are the two main clinical scenarios of erythema nodosum that we see? What's the classic form?
Like you mean like it presents like young adults?
Yeah, the red, painful lower extremity anterior tibial paniculitis nodular lesions. That's the classic form. But what's another form that we see less commonly in some people? And this one you may not have heard of as much, but it's something you'll eventually hear about at some point. You'll probably see somebody with this over the course of your training.
I'm not sure.
There's a chronic form called Villanova's disease, a form of chronic erythema nodosum that can go on for years. And it isn't always located on the lower extremity. Sometimes it's on the arms or the trunk. It's a little different pattern. You look at the histology, it looks like this. It looks like erythema nodosum, but it's just more of a chronic variant of enodosum. And just realize that it's not always perfect like this, that there's a few cases, a few situations where it can be a little bit of an unusual form. They might ask that somewhere on the exam, but that's kind of less likely.
Thank you.
You're welcome. You're likely to see something like this on the test, though.
Good morning, Dr. Cockerell. It's Ellie. So here we have an enucleation. I see some surrounding fat tissue, so I think we're in the sub-Q.
Good.
Deciding between inflammatory and neoplastic, I think that there are more inflammatory cells. I see some lymphocytes.
Yeah.
The entity itself is like almost circumcised in a way. There seems to be like a capsule with this like fibrotic tissue to it that kind of, and that fibrosis goes throughout the center of the lesion as well.
Okay.
So then we kind of get down to the bulk of it, and it's, you know, these clear, circular, I don't want to call them cell spaces. And then some of them kind of have this more kind of purpley, like kind of wispy material in it.
Good. This, if you actually notice this here,
yeah.
can you
The
appreciate
gray.
that that looks almost like it's almost like a structure there that's surrounded
Yes.
by some inflammation and some fibroplasia.
Yes.
Some of it's kind of got that purplish kind of stuff, but others are almost look sort of almost like plastic, if you will.
Yeah.
It's got a little hole in the middle of it.
Yes, it does. So I was thinking that this was some sort of foreign body reaction.
Yes.
And then, you know, looking at all the different options for that, I was favoring a silicone type reaction.
Okay. Now, silicone, what does that usually look like when you see silicone in the skin?
Well, so when it was in the sub-Q, it was kind of these kind of discrete circular globules, and they were sometimes, it looked like being like gobbled up by macrophages.
Usually when you see silicone,
Mhm.
of tiny bubbles. There's an old song, I believe, by Don Ho that he sang back in the 1950s or something called Tiny Bubbles. I think he was talking about champagne bubbles. And if you look inside silicone, you get these little tiny bubbles that are inside histiocytes and often kind of freely floating in the dermis, but they're tiny little bubbles and they vary in size and shape. Just like if you looked at bubbles in a champagne glass, you know, those are tiny little bubbles of varying size and shape. Notice that these are pretty large structures. They're not little bubbles within histiocytes. They're kind of sitting in the dermis, and then you've got cells kind of surrounding, walling them off.
Yeah.
Fibrosis and granulomatous inflammation, but they're almost like little BBs, if you will. They're plastic, little plastic BBs with a central hole, and there's a lot of them. And that isn't really what silicone looks like, because that looks again like little teensy tiny bubbles inside histiocytes and then some outside in the dermis, but it looks as a different morphology.
Okay.
So does that give you any clues as what you might be dealing with here?
Other options, I was thinking like silica.
Silica. Now, what is silica? Silicone
Mhm.
is a you know, the silica is the actual, I believe, is it SI? That's silicone, right? And that's silica is a crystal of
Correct.
silicone.
Yeah.
So that basically, when you see that, you see it's like glass.
Mhm.
Silica. And so that's going to polarize, and you're going to see angulated linear structures there because it's a crystal.
Okay. I'm not sure. I'm trying to think of other plastic things that we might inject into people.
Yeah, well, what do you inject into people? What are some things?
Filler.
We inject a lot of stuff today, right?
Yeah. It could be filler or.
Yeah.
Okay.
Filler. Which
Awesome.
filler is this most likely to be? Now, I'm not a filler guy. I don't inject fillers. The only filler I've ever injected in my life was collagen years ago when I was a resident. I don't inject Botox. I've injected Botox for hyperhidrosis, but I'm not a cosmetic dermatologist really at all. So I don't inject these, but a lot of my colleagues and friends do. And so what are some of the things that they're injecting? And the board likes to ask this now because everybody's injecting them. They want you to recognize some of these reactions now.
Could it be hyaluronic acid?
Hyaluronic acid. And what does that look like when you see that under the microscope?
Well, is it kind of more plastically clear?
Well, it actually looks kind of like blue-gray jello.
Okay.
Jello. It looks kind of like it's fractured. So if you look at colloid milium, which is degenerated solar elastosis, it kind of looks like bluish-gray fractured jello a little bit. That's what the hyaluronic acid fillers look like. if you look at the injection of the collagen fillers, they kind of look like collagen. They're more pink. But then when you start injecting some of the plastic type fillers, calcium hydroxyapatite, like Radiesque, those look like little small bluish purple BBs because they have calcium hydroxyapatite in it. And then there's this stuff, which is basically almost kind of like a plastic. This is the polymethyl methacrylate filler injection.
Okay.
So these are more permanent fillers. You know, these are things like plastic and calcium hydroxyapatite. They're permanent fillers. Silicone is a permanent filler. The hyaluronic acid fillers, Juvederm, some of those are not permanent. You know, those eventually will kind of gradually break down, and they look a little different. And those usually, if you do get an inflammatory reaction there, it's usually kind of a granulomatous reaction. And it's less common to get reactions to hyaluronic acid because your body makes hyaluronic acid. But some people, there's tiny impurities in there and there can be overly sensitive to that. These, you do usually get fibrosis and some inflammation there. And, you know, that's how you kind of get rid of the wrinkle or whatever, because it kind of remodels the skin and this stuff sort of stays permanently, but occasionally it'll develop a nodular area and it's maybe some slight discomfort or pain and the patient wants it removed and then take a biopsy and this is what it looks like. So this is polymethyl methacrylate. So I would recommend learning what all the different fillers look like. We can put some others on here for you guys for some unknowns because they do like to ask that now because they're so commonly injected and we see people getting reactions to them.
Awesome. Thank you so much.
So that's good. Okay, this was the last one.
All right, I'll take this one. Okay, so at low power, I can already see kind of that pseudo epithelial hyperplasia creating this warty verrucous surface kind of.
Good. Excellent.
You also can see a lot of thick crusting in the stratum corneum.
Okay.
When you zoom in, you see a lot of parakeratosis. I also saw some neutrophils in the stratum corneum as well.
Okay, very good.
And then within the epidermis, we see these islands of those palisading basal keratinocytes.
So you think this is an inflammatory reaction?
Well, I thought there were two things going on because I see lots of inflammation. Right in the center there, you see a pocket of neutrophils.
Okay.
But it also looks like something neoplastic going on as well, given all this. There's clear cell changes. I see that palisading pattern. But then there's a lichenoid dermatitis going on right in the papillary dermis.
It's got a mixture of infiltrate here. What kind of cells? We said you saw some neutrophils there.
I saw neutrophils. Within these islands, it's mostly plasma cells and lymphocytes.
Plasma cells and lymphocytes. And then let's keep scrolling around here.
There's a pocket of neutrophils.
Yes.
Right there.
And there's probably going to be some histiocytes in here as well. Let's see if we can find some of those. Yeah, there's like a large multinucleated histiocyte there. So when you see suppuration with areas of granulomatous inflammation, what do we call that pattern? Here's a lot of histiocytes here too.
Like a caseating granuloma?
Well, caseation, that's where you get central degeneration of the collagen and histiocytes there, and you get that pink hyaline kind of material surrounded by histiocytes. You see suppuration and histiocytes. What do we call that pattern?
Like an abscess.
Well, that's a clinical diagnosis, but the pattern is suppurative granulomatous dermatitis. Suppurative granulomatous dermatitis. And you said it at low power, you said, I see all this pseudoepitheliomatous hyperplasia. So that also goes along with suppurative granulomatous inflammation. So when you see that pattern, what do you think about? What things instantly come to mind from a differential diagnostic perspective when you see this pattern?
Well, when I see pockets of neutrophils within the epidermis, and then I see confluent parakeratosis, immediately I would think of psoriasis.
Do you get that kind of, that sort of pseudoepitheliomatous hyperplasia with psoriasis?
Not really.
No, you don't. And do you get granulomatous inflammation with psoriasis?
I thought it was possible, but I guess not.
Not usually. So we see suppurative granulomatous dermatitis The most common cause of that is like ruptured cyst, ruptured folliculitis. But the second most common, and if you get marked pseudocarcinomatous hyperplasia, then the most common is what do you think about?
Some kind of infection.
Yes, yes. Infectious diseases.
Yes.
And especially when you get this pattern, deep fungal infections.
Right.
Deep fungal infections. So when you see this, I want you to think about, never forget it in the rest of your life. I want you to think about when you see this suppurative granulomatous inflammatory reaction with pseudocarcinomatous hyperplasia like this, it's basically a deep fungal infection or possibly AFB until proven otherwise. So if you get this on the exam, it's just like the little book we used to read our kids when they were growing up. We're going on a bear hunt. You're going to go on a bug hunt. So you're going to be looking for organisms here. And the best places to look are in these areas where there's suppuration. Notice there's also some eosinophils here. And also if you see any multinucleated histiocytes. And then another place is in the epidermis and the cornified layer, because these lesions actually will transepidermally eliminate the organisms through here. So look up here, look inside histiocytes, and then look in areas of in the epidermis where there are those abscesses that you noticed.
Mhm.
So sometimes you can see organisms readily, easily. Sometimes it's hard to see. On a board examination, they're probably going to give you where it's not going to take you forever to find one because you don't have all day. They're just going to give you like, you know, you only have 2 minutes a slide or whatever. So they're not going to make it where it's difficult to see. I don't see any right here, but we do have a PAS stain over here, which was also submitted. And I believe here we were able to find some. I'm not going to spend a gazillion minutes looking here either, but I think there were some zones where we actually saw, you know, that's not the world's best there. Some broad-based budding yeasts were seen. And if we looked long enough, we would find them because I know they're in here. And if we saw those, what would the diagnosis be?
Oh, like blasto.
Yeah, blastomycosis, North American blastomycosis. So I'm not going to spend the next couple of minutes just searching for this to find it for you, but go back and take a look at this. They're in here somewhere. I know because we saw them. So sometimes they can be kind of difficult to see, but this is where you want to look. You know, you look inside the histiocytes and say, well, you know, maybe that's one right there, you know, and look in the abscesses and see if you can find it. That they're going to show it on the board examination. That's going to be pretty obvious. Now, if you see this in the real world and you see this pattern and you look hard, you don't actually find any organisms. You think in terms sporotrichosis is a common situation there because sporo can give you lots of this pattern with suppurative granulomatous inflammation with multinucleated giant cells and pseudoepitheliomatous hyperplasia. That might be an organism right there. And you don't see organisms very frequently in sporo. So in the real world, if you say, well, this really looks infectious, we really believe it's infectious, we've looked for organisms, special stains, we haven't been able to find it, that favors sporo, just so you'll know as a practical point. But cultures are way better than special stains. We like to think that we can find stuff under the microscope, and we often can, but in some cases we often don't. So that's why you really need to do cultures on these kind of cases. And again, we know it's here because we saw it, but I'm not seeing it really obvious on this scan slide. Other things to think about would be chromomycosis. That they probably show you that on the exam because you can see that without a special stain. Histo usually doesn't give you this much epithelial hyperplasia. Coxy, that's another one they like to show because you can identify the organism there. So just know your bugs, know what the organisms look like. You're definitely going to get a question about that on the examination. You can just take it to the bank. All right, any questions about anything?
No, thank you so much, Dr. Cockerell.
You're welcome. So feel free to go look at this again if you want to review it, and we'll get you another set of slides to go over for next month.